Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra, Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today we're excited to discuss a topic that probably affects nearly everybody at some point in their lives, and that's headaches. Headaches come in many forms, from a mild discomfort after a poor night's sleep to chronic and debilitating migraines. We're excited to speak with our guest and topic expert about what headaches really are, why they're so prevalent, what we can do about them, and what research might offer hope for relief in the future. My guest is Dr. Noah Rosen, who serves as the Neurology Residency Program Director for North Shore University Hospital and Long Island Jewish Medical Center. He's a practicing neurologist and pain management expert specializing in headache medicine. He's also an associate professor at the Zucker School of Medicine at Hofstra, Northwell. Noah, thank you for taking the time to talk with us today, and welcome to Well Said.
Thank you for having me. It's really my pleasure to be here.
So I've made it a habit of asking each of my guests in the last year how they've been managing through what has been an extraordinary year. So how have you been managing?
Very well, and thank you for asking. I really feel blessed to be part of our greater medical community, especially Northwell, especially in neurology, and even more so amongst our neurology residents. I know this year was difficult at first, juggling this new issue along with everything else that we usually manage, but I have to say that we have really surged ahead with great advancements in our field in this last year.
Well, I'm excited to get into our conversation and learn more about that. So let's start our conversation about headaches. And I'd like you to start by helping to clarify the terminology we often hear when we talk about headaches. We talk about cluster headaches, tension headaches, migraine headaches. Just kind of provide a little bit of context for our conversation. Are all these things different?
In the early 1980s, the International Headache Society came out with the first classification of headache disorders. And what they did is they broke headache disorders into primary and secondary disorders. That is, ones that were secondary to other conditions, say brain tumors and abnormal blood vessels. And then primary headaches, where the headache itself was the major condition. And that included a range of very common conditions like migraine headaches, tension-type headaches, and cluster headaches, which are all quite different and have individual characteristics, but are far more common than secondary headaches alone.
So let's talk about the kind of classification of primary headaches, that is, headaches that aren't caused by some other problem in your head. Could you just give us a rundown about what distinguishes, say, a cluster headache from a migraine headache from a tension headache?
So tension headaches are the most common headaches that are out there. Nearly 40% of the population will have them on a regular basis, and they tend to be more dull, vice-like, or band-like pain that's mild to moderate without other associated features. And most people oftentimes treat it with time, with sleep, or over-the-counter remedies. Now, that's different than migraine headache, which is the most common severe headache disorder. And that's really characterized by moderate to severe pain that is throbbing in quality, often one-sided, worsening with movement, and comes with other associated features like nausea or vomiting, sensitivity to light, and loud noise. Now, both of those are more common than cluster headache, which is a relatively rare condition affecting about 1 in 2,000 people. but is characterized by a very different quality of pain where people get agitated, restless, they have tearing of their eye and nasal drainage and can't really sit still for the periods of time that these debilitating events occur. So it's very important when evaluating headaches to really pick out some of the characteristics of each one to help understand what exactly it is.
And just for completeness, you did mention that there are other things that are in the kind of secondary headache category. Could you just explain a little bit more what you mean by that?
So secondary headaches are headaches that are caused by other abnormalities, whether they be related to strokes or abnormal blood vessels, like where veins and arteries come together. They can be associated with brain tumors, with infections, sometimes with psychiatric conditions or other inflammatory conditions. So these type of headaches are much less common than the primary headache disorders, but they're the ones that we're concerned about because they can be much more dangerous and progressive if they don't go recognized.
So that leads me to an important question from the patient perspective, which is, when should somebody seek medical attention for a headache? Either a single one that's really bad or a pattern of headaches that maybe not be as severe but are recurrent?
Well, let me first address how one goes about taking care of a new onset of severe headache. So that circumstance, one wants to be sure that they're not missing a secondary headache. And sometimes for those red flags, we have a mnemonic called SNOOP. And SNOOP stands for secondary risk factors or systemic symptoms. That is, does somebody have an underlying condition that may put them at risk for a dangerous headache? We also look for other systemic symptoms like fever or weight loss that would be unusual with migraine. The N in the mnemonic stands for neurologic features. So if somebody has a focal neurologic deficit, then that's something we need to be concerned about. Now, sometimes
could you just stop there for a second?
Sure.
Could you just stop there for a second? So when you say focal neurological deficit, what do you mean by that?
So I mean an abnormality in their neurologic exam, say weakness of one extremity, abnormal sensation, or something else that's not normal on testing.
Keep going.
So the other part of the mnemonic SNOOP that we want to be concerned about would be whether the onset was sudden or severe. Many headaches can start gradually and get worse, but sometimes a thunderclap onset headache can be a warning sign for a devastating event. The other O stands for an older age of onset because the peak incidence, that is, when migraine initially starts, is usually in the teen years and peaks by the 40s. So new onsets of headache in the population that's older may be something more to be concerned about. And finally, if the headaches change significantly from the past, that's also something that often requires further investigation.
What you just laid out is how you, as a headache specialist, would think about determining the risk that the patient in front of you might have of something more than just a run-of-the-mill headache. But I do want to get back to the question, to look at this from the patient's perspective. If I wake up with a headache, how do I know it's time to call Dr. Rosen as opposed to time to take a couple of Motrin and hope it gets better?
Well, in a lot of cases, it's a question of looking at the past history. Have you had events like this before? Has other people in your family had events like this before? If it is, but it's been continually going on and disturbing you or interfering in activity, then that's something that you need to go see somebody about. If it's also something new or different than what you've had before, that's also a very good reason to go and seek out some further insight as to what may be happening.
And what about the severity of the headache? Would you advise people if they cross a particular, I don't know, threshold of discomfort, that that's something that they should seek medical attention about?
Well, severity is very individual. I'm not a big fan of scales from 1 to 10 because one person's 7 is not always another person's 7. I think that where one can make a determination is if it interferes in your usual activity. That is, if you're not able to take care of things at home, at work, at school, or with family, then that's really an issue that needs to be addressed more urgently.
And I'm assuming, based on what you said before, that if somebody has a new neurological deficit, if they notice weakness or change in their speech or change in their vision, that would be an important reason to seek immediate medical attention, right?
Any persistent change in those symptoms, weakness, numbness, ability to use, to speak, to hear, to see things the way you normally would, absolutely should be evaluated. Even if they're brief and return to normal, what we sometimes see with auras associated with migraine, when this first occurs, it still deserves further investigation.
So Noah, you were saying that if there's been a change in the pattern of headaches or if it's severe enough to interfere with your everyday life, then that would be a reason to seek medical attention. I guess based on what you said before, I would assume that if somebody has a new neurological deficit, meaning they have weakness or slurred speech or change in vision, that would be a reason to seek medical attention for a headache right away as well. Is that correct?
Yes. So, those focal deficits, those abnormalities, particularly if they're more continuous, that is, that they don't disappear over time, should definitely be assessed and quickly. Now, sometimes we do see those deficits with a migraine, what are called aura, and oftentimes visual changiness or weakness. Those usually only last 15 minutes to an hour, but even the first time that occurs, it deserves further assessment and evaluation.
And under what circumstances should somebody with a headache expect that they're going to get some imaging study, an MRI or a CAT scan of their head? And I guess the flip side of that is, as a headache specialist, when do you think it's important for somebody with a headache to get an imaging study of their brain?
Oftentimes, if you end up in an emergency room for a severe headache, you will receive imaging, and most commonly a CAT scan, although there's a lot of debate whether or not people receive more CAT scans than they really need to. That a lot of it is driven by the history. If somebody is now having a change in the type of headaches that they've had before, if this is a new onset of daily headache, if it's a headache that has other complicated features or associated deficits like we spoke about, those are reasons that you would want to go and get imaging done. Especially if the physical exam is abnormal, that's a high suspicion and reason to go get imaging done right away.
You said that we're probably doing more CAT scans than we should. What's the downside of that?
So the American Headache Society and the American Academy of Neurology a few years ago came out with a consensus statement about this, that many people were receiving unnecessary radiation or unnecessary delay of care rather than having a good, adequate history taken and early treatment with acute medication started.
Okay, so there are real costs, not just financial, but there are reasons why it may be in the patient's best interest to not get an imaging study.
I think any test should be thought about and just not reflexively ordered.
All right, so fair enough. I do want to make sure we spend a little bit of time talking about migraines in particular, because I think that there's a lot of questions that people have about that. But before we get to migraines, I want to just ask you another question about the sort of more run-of-the-mill headaches that are fairly common. Is there any sort of general health advice that you have that helps people prevent headaches?
Absolutely. Headaches serve an evolutionary purpose. They're warning systems for things that might have gone awry, that is, not enough sleep, not enough hydration. Now, in some cases, this warning system fires without clear cause and actually can be disabling in itself, but sometimes these headaches are very responsive to good health hygiene or headache hygiene. So regular sleep, adequate hydration, regular meals, all of these are very important, as is adequate stress reduction. And recently, a good study showed 2.5 hours a week of moderate activity also could show a reduction in headache total numbers.
Really? So sort of basic taking care of yourself, it sounds like, is a way to help reduce the overall burden of typical headaches. Is that fair to say?
Absolutely. Poor sleep, dehydration, skipping meals, these aren't good for many health issues, but it's well documented the impact that it can have on headache frequency.
And I guess it almost goes without saying that alcohol plays a potential role here too.
Alcohol may be a trigger for a number of people with migraine. Hangovers more common amongst migraine sufferers. Now, when you look at other food triggers, caffeine or really caffeine withdrawal may be a trigger for a lot of people. MSG may be a trigger. And again, high salt foods can exacerbate symptoms of dehydration.
That's interesting. So you mentioned migraines again. So let's turn our attention to migraine headaches. What is the most distinctive feature of migraines?
Well, Richard Lipton, who is a headache specialist and excellent epidemiologist, asked this question that if you only had a moment or two to diagnose, what are the best questions to ask? And he showed that if you asked if somebody was disabled by their headache, did they have sensitivity to light, and were they nauseated? If somebody answered yes to all three, that was over 95% sensitive at picking up migraine events.
Could you comment on the association of migraine headaches with other kinds of medical conditions? I know, for instance, that it's often said that people who are more sensitive to car sickness or were sensitive to car sickness as kids are more likely to get migraines as adults. I mean, are those kinds of things true? And are there other associations like that?
So migraine has a lot of comorbidities, that is, other conditions that we oftentimes see in association that can influence the frequency or severity of individual migraine attacks. So those include neurologic issues like epilepsy or essential tremor. It can include cardiac issues, atrial septal defects, or other blood vessel abnormalities. There are associations with many other medical conditions that oftentimes can complicate the migraine headache itself. Now, one thing that triggers migraine in many people is abnormal sensory information. So that can come from sinus inflammation, it can come from neck pain, or it can come from abnormal vestibular or visual input or inner ear input. So those things can worsen or trigger off migraine attacks because the noxious stimuli sets off this more central process.
Is it the case that more women than men get migraines?
Yeah, unfortunately, women suffer migraine about 3 times more often than men. It's about 18% of women and 6% of men, which makes up, just under 12% of the population.
Is it understood why that's the case?
Well, I've heard more than once that men cause migraines more than they get them. But the fact is that we don't really know why that's the case. Now, the menstrual cycle is the second most common trigger that people identify after stress, although I have yet to see the medical issue that stress makes better. But with menstrual migraine, very classically, the headache can start 2 days prior to the cycle to 1 day in, sometimes at the end of cycle or at ovulation. So it is such a strong trigger that if one does have that predisposition of migraine, then part of it may be that it is triggered off by the hormonal cycle. But that still doesn't explain such a higher rate amongst women than men, and we still don't really understand why that.
Okay. Well, I know there are now new therapies available for migraines. Could you speak a little bit to the newer treatments available for migraine sufferers?
I can't say it's ever a great time to be a migraine sufferer, but I will say that now there's a lot more options for people than there ever were before. You and your audience may be most familiar with those medications that see a lot of advertisement online or on TV, including the CGRP antibodies and antagonists. So these are both preventive treatments and acute treatments for migraine, which work on the inflammatory signal CGRP, or calcitonin gene-related peptide. That's why it's easier to say CGRP. This is a lot like histamine in the skin when somebody develops a welt. It's an inflammatory material that signals in the brain and is part of the migraine mechanism. So these new medications either block CGRP or they bind to it to help either acutely or to prevent the headaches from coming on. Now, I should say there are a lot of other new advances that have come out in the last couple of years, including non-pharmacologic treatments, that is, a few devices on the market that can either be electrical stimulation devices like the Nerivio or Cephaly devices or magnetic stimulation devices, all of which have a moderate degree of evidence. And actually, there was just a wonderful paper in the last year out of Wake Forest on the use of mindfulness training to also help teach people how to have their individual behavioral skills to help deal with migraine attacks as well. So there's been a lot of advances, both pharmacologically and non-pharmacologically, in the last few years to really treat people individually.
And I guess it may come as a surprise to some people that Botox is also used to treat migraine headaches. Could you comment on that?
Yeah, so I do a lot of Botox in my own practice, and this was noticed back in 1992 that patients who had received cosmetic Botox had benefited, some of them, with their headaches, and that set off almost 10 years of different studies trying to figure out exactly who it was that responded. They realized it was actually those that were on the worst end of the spectrum, that is, people with chronic migraine, which means that they had headaches more than 15 days a month for at least a 3-month period, where they didn't really respond to other oral preventive treatments we had. And they showed with the use of Botox, and it's done actually, it's far more extensive than cosmetic. It's done in 31 sites every 3 months. It takes about 15 minutes or 20 minutes to actually do. But it showed a reduction in this refractory population of around 9 days a month, which was a significant improvement for these people that are truly suffering.
Is the mechanism known? Like, why does Botox work? Do we know?
And again, we don't know for certain. However, it doesn't seem to be the motor effect of the Botox that's helpful. It actually affects abnormal sensory feedback to the brain. So Michael Oshinsky, who's now at the NIH, had done some studies in rodent models where they showed that you could actually influence frontal lobe activity by peripherally injecting Botox, that is, by decreasing the sensory feedback. And that seems to be the mechanism by which it reduces migraine, by increasing or decreasing the central sensitization and stabilizing abnormal firing in the brain.
Yeah, that's really interesting. So we're coming to the end of our conversation here, and I would ask one more question, which is, where should our listeners go if they're interested in learning more about headaches or headache management?
Well, I'll tell you, there's a lot of nonsense out on the internet, so you have to be very careful where you get your information from, because some of the treatments are not evidence-based and can frankly be even dangerous. So I generally recommend that my patients go to the wonderful online resources at the American Migraine Foundation or at the American Headache Society or the Migraine Research Foundation, all of which have some excellent, validated, patient-friendly information.
Well, that's terrific, and we'll provide those links to those sites on our website. With that, I want to thank you very much for joining us today.
Well, thank you so much for having me here. This is still a population that's under-recognized, underserved, undertreated, and the opportunity to be here today is really important for all of them.
Well, thanks again for joining us. For more information about this program and to find past episodes, please visit sites.hofstra.edu/wellsaid. You can also subscribe to our free podcast available on Apple Podcasts, Stitcher, or wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.